Hello and welcome back to heart failure and structural failures of the old cardiac system. This next segment is going to be about manifestations and some more stuff. So I'm going to share my screen. We left off on this particular screen where I showed a picture of the enlarged ventricles, that dilated heart failure. The ventricles fill up, no problem. No muscle to push. And then in B, there's too much muscle and there's not enough space for that ventricle to fill. So moving on. There we go. Thank you. So pulmonary edema, what happens when you have heart failure, and I mentioned this in video 1 too, is you can get pulmonary edema. That blood just is not flowing through the lungs well enough, and then the fluids leak out of said vessels, just like in dependent edema as well, but this happens in the lungs. So what this creates, how this manifests for our patients, for our clients, is people will be anxious and pale, cyanotic. This is all because of lack of oxygen. They'll be short of breath. They will be moving, makes them even worse. They will have a rapid heart rate, or a rapid breath rate rather, tachypnea. They will have paroxysmal nocturnal dyspnea, which means they can't lay flat without getting short of breath. They'll be using their accessory muscles. When they cough, they will have like a frothy, blood-tinged sputum, crackles and wheezes. This is kind of a late thing. Don't wait around for, don't wait around for the frothy blood-tinged sputum before you start suspecting they have pulmonary edema. So just don't wait for it. You'll hear crackles and wheezes because the heart muscle itself isn't getting enough oxygen. The baroreceptors aren't getting enough oxygen. That creates an increase in heart rate on a systemic level. Sometimes it manifests itself as hypotension. Sometimes it might manifest itself as hypertension. And then you might have some abnormal heart tones, a kick, or like an extra little something or other after. It does not sound like lub dub by any means. So just be aware that when you have somebody who's a little bit anxious, who has been having a hard time with their heart anyway, start working them up for pulmonary edema and see if we can't maybe intervene sooner rather than later. Here's a visual about what happens. So in pulmonary edema, and this is from somebody in England, and they spell edema this way. So in normal alveoli, there's no fluid buildup in the lungs. And in pulmonary edema, what happens is that fluid buildup leaks, or it starts happening in the alveoli. So even though these alveoli are completely normal, like no COPD, no emphysema, nothing like that, that fluid buildup happens, and then it leaks into the lung tissue itself. And then that's how we hear the crackles. So just in general, like other than like pulmonary edema, which is a severe, immediate, like medical emergency side effect, when you have somebody who has chronic heart failure, this is what they're gonna have for manifestations. This is what you're going to find in your subjective interviewing and then in your objective assessment as well. They'll complain about how they're tired, how they can't catch their breath, how they can't catch their breath when they're laying down, either because they're sleeping, that's the paroxysmal nocturnal dyspnea. Orthopnea is changing positions and they're having hard times breathing. These people may have a cough. It might be dry, it might be, but that's just the lungs trying to clear out that pulmonary edema sort of stuff. Or that's just the lungs trying to get some clearance to be able to distribute that oxygen, because for whatever reason, that's one of the things that our first our first reaction of our body when we're not having proper oxygenation and we're not having good gas exchanges to have a cough. You'll have tachycardia, that heart rate goes up. They'll feel palpitations, they'll feel fluttery, they'll feel all sorts of weirdness in their chest. They'll have sleep problems, probably from this paroxysmal nocturnal dyspnea and just in general. They may complain of angina or chest pain. They may not. They may have weight changes. And it's really easy for these people to gain weight because they'll get dependent edema. Speaking of edema, you can have dependent edema. You can also have, what will happen is all of, like, let's say for whatever reason, they can get the edema out of their legs. They might not be able to get it out of their abdominal cavity. Remember that inferior vena cava goes from basically the hip bone area all the way, and it has to go through the liver to be able to come back into the right atria. So you may have some liver, you may have some abdominal cavity edema. You can have some lung edema, like we talked about in pulmonary edema just not too long ago. If you've got dependent edema, it may be pitting in nature. So when you give it a little push, it does not spring back. You can have changes in urine output. They can have frequent urination at night because when they lay down, all of that swelling can come back into the heart, and then all that fluid coming into the heart gets processed by the kidneys, and then the kidneys are just like, hey, here we go, let's process some stuff, and then let's kick it into the bladder, and then it needs to come out. And that's why they have the nocturia. It's because the system is aided by laying down. Skin changes, neurological manifestations, and there may be mental status and behavioral changes as well. So, and all of this is related to a lack of oxygenation in those tissues. Heart failure complications, not just manifestations, but complications, how this heart failure impacts other things, is through things called pleural effusions. That's where that edema fluid from the alveoli leaks out of the lungs even, and then pools outside of the lungs, but in that thoracic cavity. You can have dysrhythmias, you can have dysynchronous contraction. Dysrhythmias, there's electrical conductivity problems between that AV, SA, and bundle of His. Dysynchronous contraction, the electrical signals are getting all wackadoodle and they're not synced up. If you don't have AV, SA, AV, SA, AV, SA. It could be at the atrial or ventricular level. You could also develop a left ventricular thrombus. That's bad because a left ventricular thrombus will like pop up here very, very easily, or it can like break apart and then cause an MI in the coronary vessels. There's also something called cardiorenal syndrome. Cardiorenal syndrome is something where, because the heart is not pumping as effectively as what it should, the kidneys are the first down the line organ that gets perfused after the heart itself. So this heart not pumping creates problems with the kidneys because they're not getting enough oxygen either, and it can cause tissue death there too. So not only does the heart impact itself, but the heart will actually impact and start causing kidney failure. So you can have somebody who has chronic kidney disease and it's actually not caused by like diabetes, and it's not caused by buildup of uric acid. It's actually caused by the heart failing, and that's what's causing the tissue damage in the kidneys. And then we can also have anemia, where there's just not enough RBCs and hemoglobin to be able to do the gas or to meet the demands of the body. What we're going to be doing with diagnostic studies, and this is the last slide that I'll talk about before I break. Diagnostic studies are used to determine and treat the underlying cause. So we're going to be doing serial vital signs, serial blood pressures, like we were for testing for hypertension. We'll be doing some of those labs that we talked about in coronary artery disease, where we're checking to make sure how everybody's lipids are doing. We'll also do echocardiogram. And we've talked about echocardiogram before too. Echocardiogram either can be transthoracic, which is it's an ultrasound, right? And either happens on top of the rib cage, or it can happen esophageally to take a look at that back part of the heart and the atria. That echocardiogram provides information on left ventricular ejection fraction. That's how we figure out what percentage of grade that ventricle is getting, about how it moves the blood out of itself. It takes a look at the heart valves. It can find effusions. It can find thrombi. And then, like I said, it can be either transthoracic through the thoracic cage or transesophageal through the esophagus. We'll also be doing ECGs. We can have them go home on ambulatory heart monitors. We can have chest x-rays. There's 6-minute walk tests. There's other scans like MRI, MUGA. There's exercise stress tests where we hook them up to a 12-lead EKG, and then we make them walk on a treadmill, and then we actually make them run on the treadmill, and then we check for heart rate changes and blood pressure changes. They can go down to the cath lab and get a cardiac cath. They can do an angiogram. There's all sorts of different sorts of diagnostic tests. Some involve radionucleotides, where we check to see how things are absorbed by different cardiac tissues. We also can do like a different sort of lab test, which is called a BNP, a natriuretic peptide test. And people who have elevated natriuretic peptides, that is sent out by a sick heart. So when the heart is unhappy, it sends out the BNP, the natriuretic peptide levels increase. So I'm going to stop sharing my screen here. This is the end of chapter 2. And with the next chapter, we'll start on interprofessional care. How do we work with others to be able to help meet the needs of our patients?